Good evening. Thanks so much for joining us this evening. We're going to go ahead and get started. I'm Paul Kwo, and I'm a professor at Stanford, along with my colleague, Dr. Reau, who directs the hepatology group at Rush. And tonight's program is in pursuit of a functional cure for hepatitis B, monitoring effectively optimizing treatment and reducing risk of complications. So thank you to Peer Review for providing the session and for GSK for providing the educational grant for this symposium. Reminder to look out for some additional polling as we go through the evening. And of course, we'll answer questions. We're all learning about this new era in hepatitis B, and we'll certainly answer them and do our best during the question and answer session. For in-person learners, here's your QR code, and you should scan to ask your questions, and Dr. Reau will be there looking at these and reviewing them, and we'll be addressing those a bit later. So please do that. It always makes it funner. And again, visit us at peerreview.com at Minneapolis Hep B, and you can see the slides and everything else after the event. Also, we're on, yes, it's now called X. Yes, we are on X, not Twitter. Okay, before we begin, we're going to do an audience assessment. Please select your degree or certification. The results will not be shown. And please select the category or role that best describes you. And how many patients with hepatitis B do you care for each month? And which of the following practice settings is applicable to you? Which of the following diagnostic tests would you conduct to confirm the diagnosis in a patient suspected of having hepatitis B infection? So we have 5 choices here. Okay, and another polling question. Based on AASLD guidelines, which of the following patients with chronic hepatitis B should be considered for treatment initiation? I won't read the choices here, but there are 5 choices here. And lastly, which of the following statements best reflects your understanding of bepirovirsen's mechanism of action and its potential role in the treatment of chronic hepatitis B? Okay. Okay, I cannot, there we go. So our goals for tonight, we're going to expand knowledge on the role of hepatitis B serologic testing and for monitoring disease activity and for helping us to inform treatment of hepatitis B. We're going to equip you with the necessary skills to initiate evidence-based treatment of chronic hepatitis B to achieve a functional cure and reduce the complications of hepatitis B, as well as we'd like to provide you with the ability to implement some expert-recommended monitoring approaches for treatment response, disease progression, detection of liver fibrosis, and of course, fibrosis, cirrhosis, and hepatocellular carcinoma. So we're first going to talk about serologic markers and their utility in diagnosing and monitoring hepatitis B infection. And again, we learned about this earlier this afternoon, but you know, up to, depending on how the epidemiologic studies are done, up to 2.4 million individuals are chronically infected with higher rates in males. And more than half the individuals infected with hepatitis B are Asian, Pacific Islander, or of African descent. And this also, not surprisingly, leads to high rates of hepatocellular carcinoma in this group and has created some substantial health disparities. When we look in the US, again, for those who are foreign-born, about 3/5, almost 60% of individuals are Asian, and then others are from the Americas, and then 15% come from Africa. But importantly, only 25% of people with hepatitis B are infected. And this unfortunately leads to many people succumbing to hepatitis B because they don't have linkage to care which can appropriately assess these individuals and put appropriate people on therapy. Because of this, the CDC has published updated recommendations for hepatitis B screening and testing in 2023, which we're going to go over. These were an update to the immunization recommendations that occurred in 2022 for hepatitis B, which also were updated. And these recommendations are designed to provide a simpler level of care, less stigmatizing implementation than the previous risk-based strategies, which, you know, historically in the US, risk-based screening strategies have rarely worked, and universal screening seems to be effective for hepatitis C and, not surprisingly, for hepatitis B as well. So now the Centers for Disease Control recommends the use of this so-called triple panel test, which includes the surface antigen, the surface antibody, as well as a core antibody, which is the antibody to the core antigen. And these three tests allow us to characterize our patients, identify those that are chronically infected, as well as those that need vaccination, as well as those who would be at risk later for potential reactivation. So let's rethink our choice. Okay, so.
One quick second.
So you're trying to find the music? We have music. Okay, awesome. So please vote again. These are the same choices in the same order that we begun with earlier in the evening. Okay. Whoop. Okay. Shall we go? So let's talk just very briefly about the life cycle. Again, this is a slide that I'm sure you've seen some iteration of many times, but this goes through the hepatitis B replication cycle. And again, it buds to this sodium taurocholate receptor here, goes into the nucleus where you form CCC DNA here, covalently circular closed DNA. This then uses the cellular replication machinery to create pregenomic RNA. You get your proteins translated. You have reverse transcriptase from the pregenomic RNA, and this is where our therapies for hepatitis B that are approved now work. You encapsulate the hepatitis B and it buds out. And in the process, the hepatitis B over time can integrate into the host genome as well. And it's this integration that makes it so difficult to achieve functional cure and also leads to a subsequent increased risk of hepatocellular carcinoma. Hepatitis B surface antigen is tests that we have typically historically ordered as a qualitative test. It's positive or it's negative, but we now know that the presence of hepatitis B complements the quantitative hepatitis B, and similarly, there are risk factors for hepatocellular carcinoma that are higher in people who are surface antigen positive. If you clear surface antigen, which is unfortunately all too rare, this is a very welcome event that occurs because these individuals have lower liver-related events, they have lower rates of hepatocellular carcinoma, and again, we don't see this spontaneously, but again, we have therapies coming that are going to be helpful in improving this functional cure rate or loss of surface antigen. So we're just learning about surface antigen levels, but I'm just going to show you what happens in the various different groups. So in the immune tolerant individuals, these are e antigen positive with very high viral levels. Not surprisingly, you have high surface antigen levels. If you've cleared hepatitis B in the immune clearance phase, that means that you have an active hepatitis and you are driving the virus down, the surface antigen levels start falling. And if you go to the low replicative phase, these are the individuals who are e antigen negative, who then subsequently have low DNA levels and relatively normal ALT levels. You see low surface antigen levels. And again, you can see here that these individuals, again, in e antigen negative, they can be generally lower than they are in the e antigen positive individuals. What about the role of quantitative surface antigen? Well, the AASLD guidance right now doesn't have a huge amount on this as far as recommendations because we haven't really been able to effect surface antigen clearance. But for those who are hepatitis B e antigen negative, if you have a low surface antigen, and a low is generally less than 1,000, and HBV DNA is low at less than 2,000, then this usually implies inactive hepatitis B. These aren't individuals you need to treat. If you have a low surface antigen level, it also suggests that you're at higher opportunity to spontaneously clear surface antigen. We use interferon rarely, but there are also futility rules on those who receive interferon for hepatitis B. These are both an e antigen positive and an e antigen negative. It can be also helpful in that if you don't see a decline, then these individuals are much less likely to respond, and it's nice that you can truncate therapy. And again, a reduction also in somebody who starts nucleoside, entecavir or tenafavirs, if it goes down, you have a higher chance of surface antigen clearance. You can stop therapy, and again, if the surface antigen level is low, actually, you're more likely to clear surface antigen over time. And if you're Caucasian, the cutoff seems to be around less than 1,000 international units, and if you're Asian, it's less than 100 international units. And if you stop these nucleoside analogs in these individuals with low surface antigen, you can wind up actually having an opportunity to clear surface antigen. The lower the surface antigen, the better. So if you have a cutoff instead of 100 of 40, you can see here that the incidence of relapse is actually much, much lower. So low surface antigen is good. And again, this will be incorporated into practice over time. So we still will have to conduct more prospective trials as we try and sort out who truly are the people who we can do this in with minimal risk of a significant relapse afterwards. The surface antigen assay is now approved in the US, and again, it's for the indications that we discussed previously. We're now going to transition to Dr. Reau, who's going to walk us through a little bit about initiating antiviral therapy and our goals of therapy.
Thank you so much, Paul. And please bring those questions in, all right? So ultimately, the things that we can measure easiest are surrogates, right? So liver histology is a little hard to, but we have surrogate for that, like FibroScan, your DNA level, ALT normalization, seroconversion that Dr. Kwo just went over. But these are all helping us to predict a patient that is going to have a better outcome defined as less progressive liver disease, lower rates of liver cancer, lower rates of transitioning to cirrhosis or requiring liver transplantation. So remember, all of the things that we're looking at are surrogates for this much more lofty goal of disease prevention. Our endpoints also change through the life cycle of the virus and how, what our expectations are as we start to engage in treatment. But also what we want to do is we work towards, newer agents and functional or even maybe sterilizing cure. And so the easiest thing is a reduction in DNA. That is not where you want to end. After that, we're looking for those seroconversions, e-antigen loss, e-antibody seroconversion, reduction of that DNA all the way to undetectable. Remember, our assay may not pick up everything we would like to see, but you would love to be at a point where it wasn't detectable by any assay because it just wasn't replicative. And then ultimately, clearance of surface antigen and elimination of CCC DNA and integrated DNA, which allow you to talk about functional and sterilizing cure. This is where our patients want to be, and they want to be in this place without being on a therapy. So finite therapy is our goal. Why did we want this functional cure? Well, if we can stop a treatment, it's going to potentially avoid any toxicity of the therapies. We think of our medications that are available for hepatitis B right now as safe long-term options, but there is still safety signals even in something that is felt to be pretty safe. That's going to relate to decreasing cost. In theory, you would also expect to see less hepatitis flares if you're discontinuing therapy, less risk if someone's getting immune modulation through either chemotherapy, IO, organ transplantation, and ultimately overall improved clinical outcomes. So all of those things pointing to that health. Pick a treatment, and part of that is dependent on when and who we're going to treat. So currently our landscape with the agents that we have and the population that is in front of us identify clearly patients that are indicated for therapy. That's if your liver enzymes are abnormal, greater than 2 times the upper limit of normal, which is defined by 25 and 35, 25 for a woman, 35 for a man, so not by 2 times your lab's upper limit. And then replication, so greater than 20,000 if you're E antigen positive, 2,000 if you're E antigen negative. The patients that should not be treated are those that have normal ALT and minimal replication, less than 2,000. Then everything else in between there is a gray zone, and regardless of where you fall on this, clearly not, mostly gray, or absolutely, you require monitoring. So if you choose not to treat your patient, you have to have a monitoring plan that patient is in agreement with. You choose to treat your patient, you still have to monitor your patient. And even those that have no indication for therapy right now still need to understand that they likely have liver cancer risk and certainly risk of reactivation if they would have immune modulation. And so you can never send the patient out the door and never expect them back. So let's go to our polling question now. I want you to rethink your choice. Based on the AASLD guideline, which one of these individuals would you like to treat? Tom, who is there, Sarah, Joan, Larry, or I am still not sure. And it's okay if you're not sure. And remember, this is based on the AASLD guidelines, which are from 2018. We hope to have new ones soon. There was a hope that we might have them by AASLD, but I think that's not a real hope. All right. So the current landscape has limitations which are partially just by therapy. Now, we are getting more and more data and more long-term natural history studies that also allow us to kind of understand what we have in front of us. But as our therapies change, our treatment indications will certainly change. But if we imagine what we have right now, there's probably a strong argument that we should start to expand our current treatment criteria. And if you read the fine print in the guidelines, you can already expand your criteria based on pretty much every guideline that's in front of you. But the most recent guidance that was released is your WHO guidance, and that is not only relevant for the United States, but the world, right? This is the WHO, and they came out with recommendations in March of 2024. They say that if you have any of these 4 criteria, any, so not all 4, but any of them, which include an adult or a child, of 12 or older, including those that are of reproductive age or actively pregnant. If you have significant fibrosis, greater than fibrosis score of 2 or higher, and any replication or irrespective of replication, you should warrant therapy. If you meet the ASLD criteria of a hepatitis B DNA greater than 2,000, that's independent of e antigen status, and ALT above the upper limit of normal, so a little more permissive than the ASLD, again, indication for therapy. The third, any of the following risk factors that might increase the chance that this person is going to have more aggressive disease: co-infection with HIV, Delta, hepatitis C, a family history of cirrhosis and liver cancer, immune suppression, comorbidities, and these are pretty loose, right? Diabetes, metabolic dysfunction associated steatotic liver disease. This is like right now we're treating all of America with hepatitis B. And then extrahepatic manifestations such as glomerulonephritis or vasculitis. Or if you do not have the ability to measure your hepatitis B DNA by an assay, but you have hep B surface antigen and you have abnormal ALT, you can treat using those criteria. And they do recommend therapeutic options that are similar to what we have, which is tenofovir in the form of TDF or entecavir, or if you don't have TDF by itself, you can add 3TC or FTC, which are often available to help with HIV therapy. They do also state that if you have normal ALT, none of those other things, and minimal replication, you should not be treated. And they also avoid treating those that would fall in that immune tolerant phase, normal ALT, but high levels of viral DNA if they did not have any of those other factors. So they still give you a couple of individuals where they advise against treatment currently. Why are we starting to move this endpoint down lower? Well, part of that is the integrated DNA that Dr. Kwo talked about. And you can see that this is a very small study, but very sophisticated, that looked at hepatocyte clone size in individuals that were on antiviral therapy. And they looked at paired biopsies of how many DNA integrations were there at the onset and then after a period of treatment, up to 10 years in 7 of these people. And they showed a significant decrease in integrated DNA in people who had been on long-term nucleotide or nucleoside therapy. And we think that this is important because integrated DNA increases cancer risk. When I talk to my patients, I tell them this is like putting the stop sign, half a mile after the intersection. You're putting something in that's separating out the on-off codons. And so this is increasing cancer risk in our patient population. So how should we be treating hepatitis B? Well, currently we approach things as a more inflammatory liver disease, but our shift is really to treat this like a viral infection. And if you use hep C as a nice example, we don't wait for patients to have advanced disease. We treat them because we can suppress the virus and prevent any progression of liver disease and decrease liver cancer, and plus decrease transmission. So the US also has simplified treatment algorithm for hep B surface antigen patients. They tried to make it as simple as they could. The recommendation is to look at viral factors such as your DNA, ALT, AST, and platelets, to remember to do liver cancer screening first by staging, and then in anyone who has any degree of fibrosis or is going to be on therapy or hits that magic number of 40, you should do surveillance with ultrasound and alpha-fetoprotein as recommended by the guideline. And then they say that if you meet recommendations for treatment, one of which is based on age, so now taking that goal point to the age of 30, ASLD guidelines were a little bit more conservative. We're now defining an old person at a younger time point, which is unfortunate because I'm getting older and older, and now I'm really old based on guidelines. But if you're 30 and you have a hep B DNA greater than 2,000, irrespective of viral of ALT, you should considered for treatment. And if you're less than 30 and you have an abnormal ALT, you should be considered for treatment. And then those individuals that are not appropriate for treatment based on what we currently use or the knowledge that we have are those that have normal ALT DNA less than 2,000 or under the age of 30 and have higher viral loads but a normal ALT. You're going to defer but continue to monitor them. Our first-line therapies are very safe. I implied that. We have tons of data on these because they have been used for years and years and years, so we have thousands of patient life experiences. Entecavir or tenofovir in the form of TDF and TAF are the first-line therapies along with pegylated interferon by our guidelines. There are some caveats. So if you're using entecavir, you use a milligram for the decompensated cirrhotic. It is not recommended in pregnancy, and it is not recommended in someone who has been exposed to lamivudine because of the increased risk of resistance. Entecavir and TDF have to be dose adjusted for more advanced renal dysfunction. So if your GFR is less than 50, you have to adjust the dose. And if you're using TAF, there is no dose adjustment. But if your GFR is less than 15 and you are not on dialysis, it is not recommended for that little tiny group. And then you can see, although we do consider these very well tolerated, there are still side effects that are not uncommon. For entecavir, headache, fatigue, dizziness, and nausea, and then for TDF and TAF, nausea and headache. And I would say, maybe that can be a question, or I can get Paul's opinion later, that I think the entecavir side effects have come with some of the generic entecavirs. I'll have patients that say, I tolerate the green one, but not any of those other colors. And so I think that when it was branded Baraclude, we didn't see as many side effects. That does not mean that generic entecavir is a bad choice. It just, I think it's how it's pulled in some of these other, complaints. You have to assess treatment response. No one is ever going to start something and just blindly go forward. And so if you start someone on an antiviral therapy, you want to make sure your virus is responding at 3-month intervals until it is not detectable, and then you can monitor at 6-month intervals. If your virus is not responding, obviously start with adherence. If the patient is adherent, find a friend. And if your patient who has cirrhosis, we recommend that we do not stop treatment. I know that that is an arguable place, but currently we still say if you're cirrhotic, you should be on antiviral therapy. If you do not have cirrhosis, then you're going to find those, controversial or non-controversial times of treatment discontinuation. So surface antigen loss, pretty non-controversial with a period of consolidation afterward, e-antigen to e-antibody seroconversion, a little more wiggly, and then long-term suppression in those that are e-antigen negative, probably our least desirable endpoint, but still has options in those that are willing to have very aggressive monitoring to make sure that they do not flare or relapse. How often do we meet that surface antigen loss? Well, it is infrequent. Even when we use pegylated interferon, it is still infrequent. And you can see here that over time, entecavir, tenofovir, and pegylated interferon really have less than 10% opportunity for surface antigen loss. And so when you're talking to the patient in front of you, realistic expectations are very appropriate. I like to tell my young patients that we're going to start them on something, but in their lifetime, there will be a curative option so that they kind of forget that this is not a curative option. They're going to have to be on it for a long time. And when we talk about the pipeline, this is just a similar outline to what Dr. Kwo already presented on replication, and there are targets for essentially every point of the Hep B life cycle, as well as for the immune response. There are studies looking very energetically on how to affect this virus, as well as combination therapies, which are probably going to be the most rapid way of getting a functional or sterilizing cure, putting things together. Now, we're going to step and talk about just one of these. This is not because we don't want to offer fair balance. It's because bepirovirsen, which we'll call Bepi for my own sanity, is fast-track designation as of February 2024. This is based on phase 2 trials, and there are 2 phase 3 trials that are expected to complete late next year, and so we expect to have some enthusiastic information about that next year. And I'm going to take some time to allow you to see a video on the mechanism of action of this antisense oligonucleotide, Bepi.
Hepatitis B virus, or HBV infection, is a serious global health issue with more than 250 million chronic carriers. HBV infection can cause liver diseases such as chronic hepatitis, cirrhosis, and hepatocellular carcinoma. Persistent suppression of the HBV surface antigen is necessary for a functional cure for HBV infection. However, patients with chronic HBV infection rarely have HBV surface antigen loss after treatment with currently approved first-line therapies. Antisense oligonucleotides, such as bepirovirsen, work by targeting all HBV mRNAs in chronic HBV infection and act to decrease levels of viral proteins. Results of a phase 2b trial showed that when giving a dose of 300 milligrams for 24 weeks, around 10% of patients treated with bepirovirsen with or without stable nucleoside or nucleotide analog therapy achieved the primary study outcomes of hepatitis B surface antigen and HBV DNA loss for 24 weeks after the end of treatment. Bepirovirsen is now being studied in phase 3 trials. Suppression of hepatitis B surface antigen and HBV DNA is essential to reduce viral replication, decrease liver inflammation, restore immune function, and prevent the progression of liver disease, ultimately leading to better clinical outcomes and improved patient quality of life. Other antisense oligonucleotides and small interfering RNAs are also being studied for the treatment of HBV infection.
All right, I'm not going to tell that man his liver is small. So this is looking a little more granularly at that data from the phase 2 trials. This is efficacy and safety of bepi in chronic hepatitis B. It's important to know that the bepi arms did have a loading dose, so that although 300 milligrams of therapy was what they used for either 12 or 24 weeks, they were loaded. There was also a placebo lead-in in one subset, as well as the arm that only received 12 weeks. And when we look at that on the right-hand side in the top, these are patients that were on NA therapy, and on the bottom, these were individuals that were not on therapy for their hepatitis B. And you can see the red arms are high amounts of hep B surface antigen, and the dark blue are very low or undetectable amounts of hepatitis B surface antigen. And as the patients went through the bepi treatment, the red arms significantly decreased and those blue arms significantly increased. But then as you go forward more and you stop the therapy and watch the patients, there was a clear trend of hep B surface antigen increases. And so that dark blue, which was the goal on that surface antigen loss, was a minority. And then they had actually the primary outcome of a composite. Not only did you have to have a low surface antigen level, but you had to have non-detectable hepatitis B DNA. And they only achieved that in 8% of individuals receiving NA therapy and 10% of those that were not on antiviral therapy. Hepatitis B surface antigen, though, was predictive. So I already talked to you a lot about how we can use a tool like this to better identify a patient that will have a good outcome. And if they started with less than 3,000 units of surface antigen, they were more likely to see a response. The safety data does also look good. You can see that there were very few serious adverse events. There were a few minor adverse events, and that not only did it include injection site reactions, which are common in injection-based therapy, but also some vascular and inflammatory components, and a little bit of thrombocytopenia, increased ALT, and then minor bits of renal injury that did not seem to impact discontinuation of the therapy. Now, how can you improve on this? And so this was presented at AASLD. This is looking at a very similar bepi dose, but then followed by a period of pegylated interferon. And anyone that completed then got PEG, and they were hoping that the PEG would actually push more people into that desired area. They did not find that, but what they did see is that although the outcome overall was about the same, those individuals that had responded to bepi and then got PEG afterwards had much lower rates of relapse. And so although, not a cure-all treatment, if a patient is responding and then you give them a bit of PEG afterwards, they are less likely to relapse after the 24-week observation. So follow-up polling question. I want you to rethink your original answer on the mechanism of action for bepi, and please pick one of these choices on its mechanism of action after you watch that great graphic, which I did not get to draw. It would have been not so great. All right. So in the last couple of minutes, I'm going to talk about treatment discontinuation. All of our patients wish to be stopped, but there are some patients that can be stopped safely, and then there are patients that should not be stopped, and then others that can be stopped, but not as safely. Pegylated interferon is our only finite therapy, and although I talked to you about using it after a window of Bepi, you can still use this in a treatment-naive or treatment-experienced individual, and it is a finite treatment, not highly efficacious, but if it does work, it seems to have pretty good durability. Our nucleotide and nucleoside analogs, their treatment endpoints are e-antigen seroconversion. In those individuals that start at e-antigen, go in e-antigen negative, then you really should have hesitancy stopping these, and especially do not stop a cirrhotic. But if you've had long-term suppression, you can stop a patient with close monitoring, although they often relapse and require retreatment. If they lose surface antigen, which does not occur very often, then you can give them a year of consolidation and again consider treatment discontinuation. And although there are some studies to suggest that this might change, our current dogma is that a cirrhotic patient does deserve lifelong treatment, as their risk of reactivation and relapse would be much more dangerous. So takeaways for stopping NA therapy: it can be considered after a long duration of viral suppression. Informed discussion is really important because the patients need to realize that they can't stop their agent and then just run away. We do a lot of monitoring to look for early markers of relapse or reactivation so that we don't get a clinical flare or liver failure. It should not be offered if your Hep B surface antigen is greater than 100 or, based on the rules in the study that Dr. Kwo already talked to you about, because higher than that, clearance is very unlikely. Do not yet be brave enough to stop a cirrhotic, and then decisions to stop really should be a discussion between both the patient and the clinician. All right, back to you.
Thank you. So now we're going to transition to monitoring for patients, and these are monitoring for those with cirrhosis and hepatocellular carcinoma, and what are the ways that we can detect these early. So let's go ahead and move forward now. So the long-term complications of hepatitis B, Nancy already went over with you why we treat, because we're trying to suppress inflammation. We're trying to suppress the viral levels so that the ALTs will normalize. You'll have less fibrosis, and you will have less opportunity to progress to cirrhosis. And again, importantly also, therapy reduces integrations. She showed the very nice slide showing that you can, in very eloquent work, that you can actually reduce integrations. This also reduces the risk of hepatocellular carcinoma, just like suppressing inflammation and does as well. So what are the factors that increase the risk of hepatocellular carcinoma? Well, they're shown here. And again, these are the cirrhosis from any cause is a risk factor for hepatitis B-associated hepatocellular carcinoma that contributes. And you can see here that these are some of the factors that are associated, not surprisingly: age, male sex, heavy alcohol use. For hepatitis B, there's a practical matter. I tell my hepatitis B patients alcohol is ceremonial. And if you just, the best website in the world, by the way, is the Canadian guidance, because if you just look it up, it's 2 drinks per week or less for anybody. And that's it. But for hepatitis B, ceremonial only. Smoking, obesity, diabetes, those aren't surprising. Family history, those individuals get screened right away. Aflatoxin exposure, again, not so much here, but in other continents. We've talked much about the viral levels. Hepatitis B is a carcinogen, higher level of virus, higher level of carcinogen. E-antigen positive, certain genotypes, hepatitis C or hepatitis B genotype C, and then co-infections, hepatitis delta, which is out there with hepatitis B, is really contributes to a substantially higher risk of hepatocellular carcinoma. When somebody is diagnosed with hepatocellular carcinoma, we're doing better, but still we need to do better, still more so. And so the overall 5-year survival still is low at 21%, and this is largely because we are not identifying these individuals at early stage disease. So I'm going to go over with you just some data that shows you when you survey these individuals, you really give your patients who are unfortunate enough to develop hepatocellular carcinoma an opportunity to actually have a better shot at an excellent prognosis. Again, hepatitis B is a carcinogen. When discussing with your patients, we talked about who would you start on therapy. I always like to ask them, well, do you want a higher level of carcinogen in your bloodstream, or do you want a lower level? And so we know now through the REVEAL study from Taiwan that high levels of HBV DNA are associated with higher risks of hepatocellular carcinoma, as well as higher risks of cirrhosis as well. And this is a biologic gradient. So what about fibrosis assessment in chronic hepatitis B? Well, we used to do liver biopsies, though not nearly as many as we did with hepatitis C. So we now rely on non-invasive markers, but it is important to have a grasp of the level of fibrosis in your patient with chronic hepatitis B. So here are some of the non-invasive tests, and some that are available to you immediately in clinic include AST, platelet ratio, FIB4, the serum fiber test. The others really aren't used so much in the US on the serum biomarkers. And again, many of you probably use FibroScan, transient elastography. It works well. We have MR resonance elastography as well, quite a bit more expensive and involved, but also an excellent assessment of fibrosis. And don't forget your ultrasound that you order. You can get shear wave or acoustic radiation forces elastography as well. So you have multiple tools for fibrosis assessment, and we really are evolving away from using liver biopsy for fibrosis, but rather to determine patterns of inflammation. So this was a very interesting study that was an analysis of a portion of individuals. These are a cohort of individuals who developed hepatocellular carcinoma. And what they did retrospectively is they said, okay, how many of these individuals with hepatitis B who developed hepatocellular carcinoma were actually outside of the proposed treatment criteria? Remember, we treat to prevent cancer, right? But our guidances aren't perfect. And you can see here that of these individuals who developed hepatocellular carcinoma, 46% were outside AASLD guidance, 34% out of the EASL guidance, that's European, and 64% outside of the Apostle guidance. And this, I think, is part of the impetus why the WHO expanded so substantially their treatment guidances now that Nancy went over. And that is that one of the ways to reduce the risk of hepatocellular carcinoma, remember, hepatitis B is the #1 cause of liver cancer worldwide. Steatosis, alcohol-associated liver disease, it's rising, but still hepatitis B dominates, followed by hepatitis C. And so reducing the viral load and achieving functional cure are ways that we can actually reduce the risk of hepatocellular cancer. So this was a study that showed us that antiviral therapy reduces the risk of hepatocellular cancer by 70% in those in the indeterminate phase. So these are individuals who are in the so-called gray zone that Nancy went over. We don't immediately treat these individuals, but what they did was they looked at 855 patients in an international trial, and they compared these using inverse probability of treatment weighting, and they compared treated and untreated individuals. And what they showed was that if you're on treatment in the indeterminate phase, that you are at lower risk for developing hepatocellular carcinoma, substantially lower. And what they saw was in these individuals that if you were above the age of 35, if you had male sex, surface E antigen positive, and DNA above 1,000 international units, your risk of cancer is higher. So again, we want to prevent liver cancer. If you do happen to be so fortunate that you clear surface antigen on your nucleoside or nucleotide analog, look what happens here. And so you can see here in the graph here, green is great, you've lost surface antigen. Look at your cumulative incidence of hepatic events here, so they're very, very low compared to those who have DNA. And look at your risk of HCC. DNA positive, it's up here over 8 years, you're close to 8%. If you clear surface antigen, your risk of cancer is much, much lower. So while we want to suppress DNA, which is great, and that you can see here HBV DNA negative did better than DNA positive, you still do far better with surface antigen positive. And so if we have therapies that can clear surface antigen, we hope that this will still even further bend the curve down and reduce subsequent patients' risks for hepatocellular carcinoma. And so, again, you have to screen your individuals. We use ultrasound and alpha-fetoprotein. Not perfect, but actually the sensitivity and specificity are okay. This was a trial performed in Shanghai, which is all based on just showing that you can reduce the incidence risk of hepatocellular carcinoma, and you get earlier stage cancers if you do this. And you can see here that in the screen group here that you can see 74% were stage 1 and stage 2, whereas in the control group, not screened, you can see here in viral hepatitis, most of which were hepatitis B, 63% were stage 3. These are individuals who don't have resection and transplant as options. They are qualified for either local regional therapies and or systemic chemotherapies, and obviously the prognosis is much less. Those of you who care for liver disease patients know with hepatocellular carcinoma stage 2, you can offer these individuals even transplant, which gets rid of the entire preneoplastic liver. And again, here's the impact of screening on survival after diagnosis of hepatocellular carcinoma, and not surprisingly here in the screen group, your survival at 5 years was much better than those who were not screened. So you can see here that screening does have a significant impact in this population. The 2023 AASLD guidance for hepatocellular carcinoma was recently updated, and so you can see here, all persons with cirrhosis, men from endemic countries greater than 40 years or 50 years for women, persons from Africa, consider at an earlier age. We had a prior discussion about this, age 20, because of the potential aflatoxin. And anyone with a family history of any kind of hepatocellular carcinoma, I have a very low threshold for initiating with any type of risk factor. There are risk factor calculators for hepatitis B. There's the PAGE B score, and this requires, you can get this online. There are in a variety of sources, but if the score is above 10, these individuals should also go in to a surveillance program as well. One of the most uncomfortable conversations to have with anybody who has hepatocellular carcinoma is, well, the guidelines didn't really say we needed to screen you. It's of no consolation to these individuals, and so subsequently my threshold is is actually quite low to get these individuals into an appropriate surveillance program. So we're going to hear some music, is that right? Okay, we're going to hear some music. Hang on. How frequently should HCC surveillance be performed in high-risk patients? Okay, appreciate the relaxing music. Okay, based on follow-up based on HCC screening. So there are now quality measures, and this is actually something I hope, Nancy, does your radiologist today use these visualization? Ours incorporate them, and it's been welcome. And so they will actually grade how well the liver is seen in ultrasound. If you look at your own images, right, sometimes you know the liver is not seen well. Other times, particularly with MASLD, sometimes they just don't see everything. But if they have a very, very excellent visualization, then they confidently say ultrasound AFP in 6 months. If visualization score is B, or they see a 1 centimeter lesion, AFP normal, they would start recommending every 3 to 6 months, depending. If they see a lesion, it's every 3 months, you should bring them back and repeat the AFP. And then you bring them back 2 consecutive times, and if it's stable, you can go back to every 6 months. If, on the other hand, there's growth of the lesion or any concern that this lesion is greater than 1 centimeter, then you need to do, again, a diagnostic contrast-enhanced CT scan or MRI with subsequent management of these individuals. But your bottom line is that ultrasound and AFP are where you start, and then depending on what is found, then you can subsequently either image with ultrasound sooner. Say it's a 4 millimeter lesion, you can just repeat in 3 months. But if you see a more substantial lesion, you need contrast-enhanced imaging to make a diagnosis. And as we often say, liver cancer is one of the few oncologic conditions where you actually don't need a liver biopsy to make a diagnosis. And if you're so unfortunate to have a visualization C, this usually means something like I'm missing the left lobe of the liver, or there's just a substantial part of the liver not seen, then you need to move on to a different imaging modality. It can be a bit challenging sometimes with insurance companies, but if the ultrasound report really is well documented, they're just anatomic features, we usually can get these, approved. And again, if you identify a lesion above 1 centimeter, the AFP is above 20 nanograms, or is increasing, you need a multi-phase imaging study to make sure that there isn't a subsequent malignancy that is present. If you're not treating somebody, I do, for the first year, a liver panel every 12 weeks, and we just do this just to make sure, as Nancy was showing, we look at the ALT cutoffs, but they're dynamic. So someone might be 30, but then they come back and see Nancy the next time it's 50. And that will affect, or 60, that will affect your threshold for initiating therapy. Same thing, I do HBV the first year, every 12 weeks, and then subsequently twice per year. E-antigen positive individuals, these are younger individuals. I check the e-antigen annually in these individuals, and surface antigen on an annual basis as well for me. And again, screen for hepatocellular carcinoma in the appropriate populations that we've described. For people on therapy, Nancy already went over this, but liver panel, HBV DNA, we check these, and again, the therapies work if you give them. Okay, the therapies work. You're really checking for compliance. And you'd be amazed sometimes, I'm in the Bay Area, we have lots of software engineers, and software engineers are not always 100% compliant. So, and so that's why it's important that you make sure that these individuals are taking these medicines on a regular basis, and it can be challenged because they feel fine, but ALT may be high. So that's what we do for the first year. And once you're satisfied, then every 6 months is fine. Surface antigen, again, once a year for me. And again, if you're on a therapy, and nobody's using a Defovir anymore, but tenofovir, disoproxil, does have some renal signals that need to be monitored for. So you need to be looking at a serum creatinine in these individuals and periodically looking at a UA as well. And if you have metabolic bone disease, these are not individuals that should be receiving tenofovir. So in summary, for our program, the role of quantitative surface antigen is evolving. It will be a tool that we will use in the future with the therapies, including the one that Nancy went over, bipivirsin, and I may not have pronounced BP. Okay, it is a therapy, and it will not be the only one where surface antigen levels are going to be very, very important. The goal of functional cure is to achieve hepatitis B surface antigen seroclearance, a marked departure from our current therapy goals, which is just viral suppression. And again, I think Nancy made the analogy that, for hepatitis C, we treat everybody because we can get an SVR, sustained response. If we could clear surface antigen everybody, we will be treating everybody as well, and this will be clearance of surface antigen. These new therapies are in development and hopefully will be a window to an improved functional cure rates. Again, screen appropriate individuals for hepatocellular carcinoma, AFP, and ultrasound every 6 months. Monitor for fibrosis progression as well. We're going to stop here, and we will hopefully be able to address any questions and have a discussion. And again, thanks for spending the afternoon with us.
Yeah. So I'm still monitoring questions, so send them in. We have some good questions. So in a co-infected patient with hepatitis B and C, Paul, which would you recommend treating first?
So I go ahead and treat the hepatitis C with DAA therapy, while concomitantly I put them on antiviral therapy. You do need to monitor. So hepatitis C causes, when you treat, there is a small but very real risk of hepatitis B reactivation in someone who is surface antigen positive. So in these individuals, if they are surface antigen positive, a treatment for hepatitis C is just 8 or 12 weeks, and the sustained response rate is very, very high. A cure is expected. But you need these individuals on treatment at that. You need to be have these people on treatment. And I look for these individuals, and I keep them on treatment. Do I stop the therapy afterwards? It depends. If they have fibrosis, I'm inclined to keep them on treatment for hepatitis B as well.
Excellent. So this is a question that recognizes that even though patients who have been exposed to hepatitis B, if they have healthy livers, they are still eligible to donate that liver for transplantation. So if you have someone that is Hep B core positive, do you keep them on antiviral therapy for life? So this is a person who receives a Hep B core positive organ as their new liver, maybe from their original liver disease, and now they're on immune modulation.
Yes, so these individuals, and we use core antibody livers routinely, because remember, in the world, 2 billion people have been exposed to hepatitis B, 2 billion. So 2 billion people are core positive. So these individuals can receive surface or core antibody positive livers, and you just place them on a nucleotide, usually any of the first line are fine, and you need to remain on that. In fact, we have had some unfortunate circumstances where people have accidentally stopped. I don't know if you've seen that also, and they do come in with a little bit of a hepatitis, and when our patients who are stable post-transplant come in with elevated liver tests, that's actually one of the first things we look for is, if the immunosuppression is normal or is therapeutic, then it's, were they core positive, and did they run out of their nucleoside or nucleotide analog?
Yeah, we've actually had some of our patients lose surface antigen, and we have still not been brave enough to stop their antiviral therapy, just because the consequence of, having someone who had low levels of surface antigen that didn't really reflect their risk of reactivation is just not worth it. Another question on ALT levels. So I think that I commented that 25 and 35 were ALT for men and women. There's certainly 19 and 20, what was it, 19 and
30.
30,
19, that was the
29,
Preddy
19
paper.
and 19 and 29.
Yeah.
So what do you use as your values?
So we wrote the ACG practice guidance, and we said for women up to 25 and for men up to 33 are the upper limit of normal. But all of these are roughly at the right level. I mean, 33 or 35, there's not a huge difference there. The important thing is that it's not the ALT level that at my institution right now, the upper limit of normal is 56. And I will tell you, I used to practice in the Midwest, so in Northwest Indiana, the upper limit of ALT at some hospitals is 70.
Yeah, I've seen 80.
Oh, 80? Mm-hmm. So those are ALT levels that are clearly not healthy ALT levels. We used to say that the machine analytes were the same across the machines. There's now been a very nice study that came out of the VA that showed that there are certain machines have slightly higher ALT levels on the same sample, but again, the differences aren't that high. So if your ALT is in the 30 to 35 range, in my opinion, I consider that a normal healthy ALT for a male. And a little bit lower for female. On the other hand, if it's 70 or 80, then these individuals clearly have some disease that needs to be assessed for. Yeah. And if they're surface antigen positive, I would take that as somebody that I would have no problem with initiating therapy. Sometimes it's a little bit difficult to separate out the steatosis from the hepatitis B, but again, which is easier, to suppress the virus or to get somebody to lose 10 pounds?
And the WHO guidelines would advocate for treating someone irrespective of viral load if they have a comorbid condition, of which mast cell and diabetes both count. So this is an interesting case. This is an individual who's 45 with Hep B, had a viral load of 100,000. FibroScan at that time showed fibrosis stage 3, was started on entecavir, AST and ALT normalized, but on repeat assessment a year later, there was progression to early cirrhosis. So the clinician is asking, is this a problem with the non-invasive tool you use? Is this person progressed despite the fact that they have normalized their enzymes? They didn't give me a viral load, but I'm assuming that the viral load must also be suppressed. If there's viral replication, I think all of us would talk about adherence first, and then either a change in therapy or an addition. So you can either go from entecavir to tenofovir.
Was the viral level suppressed?
They didn't tell me, but I'm hoping it was. Otherwise, that's the thing.
Yeah, but how often do you switch therapies, or do you add therapies? Because they usually work.
Yeah, I think that the old literature just added, right? So when we had adefovir and lamivudine, we combined everything because neither one was a perfect agent. Now, if I have a patient who's on entecavir and has replication on entecavir, which has been documented, it's not always adherence. Often it's adherence, but not always. I would switch them to tenofovir, preferably TAF, but TDF if that was. I rarely have someone that I would go the other direction with, just because entecavir does have some risk of resistance, and I think if you're minimally adherent with your drug, you're more likely to get resistant. But
yeah, And then in this case, if they had progression on their non-invasive test, it's possible their first non-invasive test wasn't as accurate, and that it really isn't any change, particularly with the ALT and AST being normal. But you do have to look for other liver disease. So just make sure they're not drinking, which is, and if you're not sure, there's a test called phosphatidylethanol. We call it in our clinic the fifth vital sign, and it actually can detect small amounts of alcohol and is a way just to make sure they're not picking up another liver disease or a steatosis. And then finally, although not just relevant perhaps to this case, in anyone who's progressing, I do go back and make sure somebody looked for hepatitis delta once.
Yep.
Because, and test for HIV just in case. I have actually seen that happen on more than one occasion where I thought something was done, and then a deep dive later found out that we had missed a diagnosis.
Correct. Sometimes it's been sent but didn't get, resulted or. So last question that I have is that we just came from a nice lecture in the colorectal cancer screening section talking about the mini serum and stool studies. So our guidelines for liver cancer screening emphasize ultrasound and alpha-fetoprotein. Are you using the new serum test for cancer risk, or L3 and DCP? Are you using any other tools?
Yes, so the question that they're bringing up is a panel, and so you have alpha-fetoprotein, then you have alpha-fetoprotein L3, which is a fucosylated version of L3, and it's about 10% of total AFP, and so it's the ratio. If it's greater than 10%, that predicts HCC, and then descarboxyprothrombin is an immature form of prothrombin, and what happens here is it just says, well, if you have a liver cancer cell, the hepatocytes aren't normal, so they secrete an immature protein. These tests are FDA approved, but they're actually not FDA approved to diagnose hepatocellular carcinoma. They're FDA approved to actually assess for hepatocellular carcinoma risk. Nonetheless, you can use them. And if I, for instance, have somebody who has a bit of a high AFP, I actually use the Gallup score, particularly some of these individuals, the L3 will be quite low. But again, if it keeps rising, you have to do other types of imaging. There are other emerging biomarkers out there. There's a multi-targeted DNA test called Oncoguard. But again, I essentially use that for atypical imaging type lesions, not to diagnose hepatocellular carcinoma. Typically, our use of ultrasound in addition to dynamic imaging with AFP, AFP-L3, and DCP, I think really get to where you need to, are sufficient tools in almost all cases. And if you have an indeterminate lesion, then in my opinion, sometimes you just have to biopsy.
Yes. And like you, I typically use my L3 and DCP in the patients that have a minimally elevated alpha-fetoprotein. But we do have fellows who will order one, the AFP comes back at 2, 50% of it is L3 percentage. And then they're like, well, do we have to do cross-sectional imaging? Which I don't like to go down that rabbit hole. So I try to reserve it for those that have elevated AFP.
And patients sometimes will hound you
Yeah.
on something like that. So that is, if the AFP is low, it's not nearly as helpful as if when the AFP, for instance, is 20. Then it's very helpful. Last caveat, if you're using descarboxyprothrombin, if you're on Coumadin, it's going to be high. So just don't order it there, because that will also generate quite a bit of excitement on the EHR.
Yes.
Okay.
All right. Do you want us to go through the
Keep
last
going.
slides?
Can we go ahead and keep going? Yes. So please go to peerreview.com, Minneapolis.hepatitis B, and complete your post-test evaluation for credit. There's the slide set. Hopefully it's helpful to you as you go back and immerse yourself in your practice. And again, you can watch a replay of this event in the next 24 hours, and it will be online as well. That's the last slide. Thank you all for spending a bit of time with us this afternoon. Go enjoy the rest of the evening.